All right, thanks all for joining. So today's talk will be on more of the behavioral symptom management in dementia, and we'll try to differentiate this a little bit between different dementia syndromes as it does matter, um, but we'll try to keep it more generic as well. So no disclosures on my end. So we'll want to first kind of recognize these behavioral symptoms that commonly happen in these disorders, which are often labeled as behavioral or psychological symptoms of dementia. And then, the need to sort of incorporate that multidisciplinary approach, which we'll address, because there's lots of non-pharmacologic options that actually work better and obviously have less side effects than our pharmacologic options. We will talk about medications to use and what are some better band-aid approaches versus ideally more long-term solutions to prevent and to control symptoms over time. So how prevalent are behavioral symptoms of dementia? Well, very prevalent. So at some course throughout the disease, almost everyone is going to develop at least one of these types of symptoms, obviously with severity ranging much different from one individual to another. But this is actually one of the two most common reasons for placement. So urinary incontinence and other hygiene-related issues being one, but also behavioral being one of the other major ones. So we've seen data where, patients that have dementia, many of them, 3/4 of them have symptoms of depression. And when these symptoms are present, there's a lot higher rates of transitional trauma between placement facilities as well. And these are overall just associated with a lot of comorbidities. So, as far as more rapid cognitive decline, when these symptoms are present, that's usually a clue. Worse quality of life, and then earlier institutionalization, like we mentioned in the last slide, just overall when they do get into a facility, needing to move to other places because of behavioral symptoms. So overall higher healthcare costs, hospitalizations, placement issues. And then this also puts a major strain on the family, right? So the caregiver burden and depression is significantly higher when these symptoms are present. There are some clues between the different diseases. In Alzheimer's disease, we very commonly see things like anxiety, irritability, frustration, especially with the memory symptoms early on. And I'll kind of have a slide that highlights a little bit where this happens in the course of these diseases. When you're seeing things like psychosis, visual hallucinations, paranoia, acting out dreams at night, or what we call REM, sleep behavior disorder, lots of fluctuations in symptoms. Obviously, that's where we're thinking more about Lewy body dementia, which we'll have our own talk on that in a bit, in a few weeks. But these can span from sort of paranoid delusions, misidentification, and these fluctuations. We don't really get much clues with vascular dementia. Behaviors can vary quite a bit depending on where the strokes are in the brain. When we talk about like behavior being and personality change being like the prominent symptom, way more than even memory or other cognitive functions, then we're leaning towards more of a frontotemporal dementia. And these are the cases where we'll very often see more compulsive behavior, hypersexuality, and really socially inappropriate behavior. However, it's not always that easy, right? I mean, first, I think it helps take a step back of like, what does the frontal lobe do, especially when it starts to undergo damage? And this shows you a PET scan where the front, especially the right part of the brain on this individual, is undergoing a lot of problems metabolizing glucose. So this is an FDG PET scan showing how the brain is working and where it's struggling. And from the top view, you can see the front part of the brain looks much different than the back part of the brain. This is where the epicenter of disease is, right? And this is an individual that had behavioral variant frontotemporal dementia. And the frontal lobe, what's important for doing? Well, it's important for executive function, for that sort of planning, organizing, decision-making, executing a task, judgment. So folks are at much higher risk for scams when there is executive dysfunction. The cognitive flexibility, so like troubles with routine and plan. So when the routine is broken, when the plans change, that can really be disruptive to an individual when the frontal lobe is struggling. And I sort of call it like the filter when I'm describing it to patients, right? So, what are those consequences of saying what's on my mind, right? That's what leads to that socially inappropriate behavior and some of these impulsive and careless decisions. So that's obviously like a behavioral variant frontotemporal disease case. This can also happen in all dementia syndromes. And so like here's an example where, this is a very classic Alzheimer's pattern that involves the what we call the parietal lobe and the temporal lobe on both sides. And this individual will have a lot of memory problems, more of what we call typical Alzheimer's disease, especially early on. We have some cases which do involve a large, front part of the brain. It also involves the typical Alzheimer's areas, but when we get a lot of frontal involvement, then that can lead to behavioral symptoms. And each individual's journey through this is different. Some individuals may start with this for the first 5 years, but then, I mean, you can see even here, the frontal lobe is starting to get a little bit involved, and that's why we can see evolution of symptoms over time. But certainly this is a different clinical picture from the previous one I showed you where it was behavior up front, because that's where the symptoms started in the frontal lobe rather than evolved there eventually. When we look at kind of the breakdown of the different neuropsychiatric symptoms, I really like this JAMA article, and it looked at kind of the major symptoms that occur across neurodegenerative diseases. So this went into even more detail than I'm going to ever go in for you guys. It went into even subtypes of frontotemporal syndromes. But what I like about this is, I mean, it shows you just sort of how apathy is by far and away universal in these diseases. And then depression is very common. Agitation, hallucinations is really more in the Lewy body category, and then certainly in Alzheimer's disease later on in the course of disease. So it's just a nice slide to have for your reference in the recording. I like this slide too. So this is from really two different papers. This is a edited version, but it kind of shows timeline of symptoms. Now this is specifically for Alzheimer's disease, but if this dotted line is like the date of diagnosis of, okay, we think Alzheimer's is going on, there's a lot of things that are happening years before symptoms, years being on the x-axis here. So 30 months, so about 3 years, social withdrawal. That's typically what we hear about withdrawing from hobbies or social engagements. Depression is very common early on, anxiety, and then this is frequency across patients here. Disturbances in the circadian rhythm, right? So sleep disturbances, very common. And then, it's usually later on, years after that we see more agitation, which is a very common symptom, or aggression or wandering or irritability. So this is just a nice sort of summary of those types of symptoms. When we think about an algorithm, which I will share one with you at the end, again, this is not, each case is unique. So it's pretty hard to say like, oh, you're just going to do this for every patient. That's not reality, unfortunately. And so really some of the algorithm is trying to decide, yeah, are there triggers here? Can we avoid those triggers? That's actually more important than starting a medication reflexively, right? The medications that we're going to discuss are really for folks that are not responding to those non-pharmacological interventions. If a patient is, at threat of harming themselves or others, or if, it's basically going to be a placement issue, certainly medicines are reserved for these scenarios. We always want to start these medicines low, especially in folks over 65, and to titrate up slowly. In the emergency type situation, which I will have an algorithm for that too, that may require an admission. But the risk of that is whenever you admit someone with dementia to the hospital, you're running the risk of more delirium, more confusion. And so our goals are really to avoid these emergencies, knowing that that's not 100% possible, but as much as possible. We need to know that some medicines can make symptoms worse. So like in patients with frontotemporal dementia, donepezil can worsen their behavioral symptoms. So that's why getting that diagnosis can be important. SNRIs, I find invariably can increase, like especially for patients that have a hyper anxiety / agitation, hypervigilance type of state. Sometimes that extra norepinephrine that comes with SNRIs is not helpful. And then obviously anticholinergics, especially for patients with Alzheimer's and Lewy body disease, that can worsen a lot of the behavioral symptoms that we see. And I should mention here too, I mean, anything that sort of perturbs the system, right? So UTIs, pneumonias, viral infections, COVID, that's where we could see a dramatic change in behavior and cognition, where really it's almost like delirium in some ways, like we talked about in the delirium talk. Depression often goes unrecognized. So a lot of even at our annual wellness visits, right, we'll do a depression screen, and patients will invariably say, I'm not depressed, right? I will tell you, if the patient is filling out the PHQ-9, that's often unreliable, especially when the patient has poor insight into their symptoms. So we want to take, this with a slight grain of salt and make sure that we are asking others. Sometimes the symptoms don't show up as a classic depression like you would see in somebody in their 30s, 40s. Sometimes it's more anxiety that's running the show, or irritability or agitation. So you need to ask about those questions. When there's changes in patterns, like when it's just there's worse times of the day, that can be a signal. Increased sleeping, right, or trouble sleeping. These sort of variable moods, especially when there's excessive irritability, is usually a clue. Oftentimes it's, when memory is questioned, right? No, remember we talked about that earlier. Or, you've asked me that question 5 times. When the routine is broken, like I mentioned, these are triggers for this irritability in many ways. And SSRI medications can really help with some of these symptoms. So it is important to have them on your radar. And we do see some patients respond to SNRIs, so I don't want them to be, off the table. But if you see, you need to be mindful of this irritability issue. So you want to obviously evaluate with these screening tools, but often incorporating someone else to help with filling that out, or at least have them each fill one out and see if there's a differing story there. So this is very common, like I mentioned, in at least 3/4 of individuals, and it has a significant impact on their quality of life. We generally stick with escitalopram and sertraline. Those are pretty well tolerated in folks over age 65. There is a newer one called vortioxetine, which actually has been shown to have some cognitive benefit in folks over 65. And the reason for that is because it has some pro-cholinergic effects. So kind of boosts a little bit of acetylcholine. But cost is the main issue for any new drug that we talk about. And then SNRIs can be used, especially for melancholic depression, where you're trying to kind of increase that norepinephrine level. I haven't really found any success in these dopamine agonists, although in some early Parkinson's patients, it can be somewhat helpful. Probably one of the more common symptoms I see, especially with Alzheimer's disease, is anxiety. And so if we kind of label it slightly on its own, again, there's a lot of overlap with these, but agitation, irritability, excessive worry being one of the big ones, apprehension, that sort of catastrophic thinking that occurs, rumination. So these are the things that keep people up at night when there's insomnia. It's the rumination, the constant, mind wandering and just the flow of thoughts. And so oftentimes your first line agent, just like in depression, is an SSRI, specifically one that has more of an anti-anxiolytic effect. And so escitalopram and sertraline are good choices here as well. And then same comments here with SNRIs. We do use some low doses of kind of throughout the day type, especially for maybe as needed, or kind of small doses of trazodone and buspirone can be used as well, maybe as adjunct agents though for the SSRIs. Or these would be, think of them as your Band-Aid approach while the SSRI is taking time to start working as you're increasing the dose. We have had some cases where benzodiazepines really were the only thing that worked. Like these were just extremely high anxiety individuals, but that shouldn't be your first line agent. And you do have to counsel the patient and family that, there's increased fall risk. We might even be worsening cognition with these agents. So you just have to be mindful of that, but they're not 100% off the table. A note about just one SSRI in particular, because it has slightly unique properties here. So paroxetine or Paxil, you would not want to use this in patients with Lewy body disease specifically, and not in Alzheimer's disease either, actually. We have used it in some FTD patients, especially when kind of the initial SSRIs are not working. But it kind of has a limited role in these diseases. When we look at agitation and aggression, what might the caregiver say? Because they're not going to label it, my loved one is agitated, right? They're going to say that there's a short fuse, they're easily upset, they're irritable. So a lot of the things are, from a non-pharmacologic setting, sometimes the group settings may be too stimulating. So sometimes it's one-on-one visits. There are tips as far as relaxation techniques. So some patients really enjoy music. And if it's starting to happen at similar patterns of the day, then we can sort of try to head off some of these things with sensory enhancement and relaxation, having some sort of purposeful activity, right? So sometimes patients just don't have enough to do, right? And then it comes out behaviorally. And so certain volunteering or gardening, some of the facilities that have these kind of built in are extremely beneficial. So getting that purposeful activity, physical activity. So if someone has an exercise regimen, that can really help with agitation and aggression as well. And then sometimes it's sort of how we respond, right? So some responses will result in a shorter fuse being lit faster, right? And so sometimes it's sort of a, depending on the scenario, where it might just be better to walk away or to respond differently than kind of what our normal response would have been before dementia was part of the picture. There is a new FDA approved drug, so I will mention it here. So it's brexpiprazole is the generic name, and this is how it works. That I personally haven't prescribed it yet because of this reason right here. So certainly, as it becomes more generic, that might be an option if it is covered by someone's insurance, or if you can get prior approval. It's an option. I've had some patients get started on it through psychiatrists or other providers, and it worked pretty well. But it's certainly not a magic drug either. There is a cousin of this called aripiprazole that's been available for many years. So you can utilize this. Obviously, the cost is much less, right? And one difference between the two, though, is that aripiprazole does have a slightly higher risk of Parkinsonism. So you would not necessarily want to use it in your DLB patient, but might be a good option in some Alzheimer's patients. From an apathy standpoint, so again, I kind of mentioned how apathy is really across the board an issue in all causes of dementia. Really, the best methods is sort of like a this is the plan for the day situation, right? So we see people that are in structured environments where they're just this is part of the routine of the day, do much better, right? When it is sort of a well, we'll go to the gym if you want to, right? Or maybe we'll go to dinner if you want to. That's not going to happen, right? And so some sort of structured routine can be helpful. There was a study published just a couple of years ago on methylphenidate in apathy, specifically in patients with Alzheimer's disease. And there was some benefit, most notably in the first 3 months of therapy. And this, extended beyond 3 months, but it's sort of one of those where you could consider it as a trial. And if they're not getting benefit by 3 months, then you pull it off because this wouldn't be something you'd want to keep on long term. I personally have a lot more experience with modafinil, so we use it a lot in DLB. It has better evidence in DLB, but it's also tolerated quite a bit better. And so sometimes I'll start with this and then I'll consider methylphenidate. And if neither are helping after a certain amount of time, then we'll just have a short leash on it. You do run a small risk of worsening agitation, aggressive behaviors with these, but that wasn't a major issue in this trial. From a psychosis standpoint, how does this show up? Well, sometimes it's paranoia, sometimes it's delusions. It's the classic, patient misplaces their wallet, but they don't remember where they put it. Well, the neighbor must have stolen it, right? And so sometimes that can be really hard to break. There's that's kind of their set reality. But these are symptoms of psychosis, and that spans all the way up to visual hallucinations where they're actively seeing things, or auditory hallucinations where they're hearing things. And then we get these misidentification syndromes often. So Capgras syndrome, sort of the classic, this looks a lot like my spouse, but it's not her, right? Something's off. It's a replica or an imposter version. And we see this also with places can occur. And so sometimes these symptoms are happening and the patient is able to like 2/3 of my Lewy body patients can recognize that their visual hallucinations are not actually real, or they can at least kind of walk up to it and reassure themselves. You wouldn't want to throw medications at that, but we want to definitely intervene with medications if it's starting to impact one's quality of life from a stress, anxiety standpoint. So, the first line treatment for these actually from a neuropsychiatric standpoint is donepezil, particularly in Lewy body disease. It's kind of like first, second, and third line treatment. We can see visual hallucinations completely resolve actually. And so you have to keep that in mind. And I shouldn't only put donepezil, but galantamine, rivastigmine patch, like we talked about in the talk last week. And then there's the atypical antipsychotics, which all have a black box warning of potential increased risk of death in dementia patients. So you need to at least counsel on this. And this is why we start at a really low dose. I will say this risk is very low, right? And when we're considering these, obviously the benefits outweigh the risks at that point. So some examples. So we generally stick with quetiapine. The reason being is it doesn't have as much dopaminergic blocking, so it's not going to worsen Parkinson's symptoms. And even if you say, okay, I know my patient has, I even have biomarkers. I know my patient has Alzheimer's disease. 20-25% might have co-pathology with Lewy body / Parkinson's, right? And so I think like as a first line agent, quetiapine makes sense from a safety perspective as much as anything. But its efficacy is mild in some cases. So this is still a reasonable one to start with, especially when we're dealing with psychosis. Pimavanserin is a newly approved one specifically for patients with Parkinson's related psychosis. Lump Lewy body in with that. This one is expensive, so the only reason we're prescribing is because there is some grant assistance with a specialty pharmacy. This can take quite some time to see full effect, but it can be quite beneficial in some patients. Olanzapine is another antipsychotic, but it might have a lot, it has more dopaminergic blocking effects, so we don't like to use it in folks with these alpha-synuclein Lewy body Parkinson's disorders. And then aripiprazole can worsen Parkinsonism, but a little bit less than olanzapine, so it's a reasonable option. And then the brexpiprazole, which is the new kid on the block here. Insomnia is something we deal with a lot. So, most patients with dementia disorders do have some sort of sleep disruption going on, whether it be too much sleep, too little sleep, fragmented sleep, sleep apnea, REM sleep behavior disorder. Sleep's a big deal. And we try to, there's like 100 different sleep aids out there, but 99% of them are not good for your memory. Some of them have anticholinergic properties or benzodiazepine properties. So we try to stick with things that are going to cause less side effects in these individuals. Melatonin being one where we titrate up. I really don't go above 12 milligrams very often at all, but some patients need more. And so if they say, yeah, I tried melatonin for 3 days, it didn't work for me. That's not how melatonin works. Melatonin works as a sort of a promoter of sleep, which might require higher dosing, but it's also not going to knock you out. So it still requires good sleep hygiene. It really just tries to help bolster up that circadian rhythm. For patients that have long-standing insomnia, they've been on medicines for 20 years for their insomnia, they're probably not going to be only able to use melatonin. We're probably going to need a prescription strength. And trazodone is a better option than most, at least from a cognitive bias perspective. And so we'll usually start at low doses and slowly go up over a number of weeks with a high dose range here. One caution, right, is this does modulate serotonin some too. So if you've got patients on other serotonin modulating drugs, then you have to at least counsel them on what serotonin syndrome is and what symptoms to be looking out for. And then there's the newer agents, which actually look pretty promising. So these are orexin receptor antagonists. I don't personally have much experience with them just because they're so costly, but our sleep medicine group will use them sometimes when we can get them approved. And These actually might be quite beneficial in this patient population once we get more data on them. And one of the last symptoms, so we do see some hypersexuality, usually more in the frontotemporal dementia folks. Certainly the avoiding the certain situations where these are occurring is the first line. But we also try to utilize some of the decreased libido effects of SSRIs. So sometimes using ones that have higher effects like citalopram and really going up higher on the doses. So that's one that we'll use there. All right, so I'll wrap up with two just algorithms here. So, I think step one of managing any psychiatric symptom is looking for any treatable or reversible conditions, right? Sometimes that is pain, right? Sometimes that is the fact that somebody's on anticholinergic medications. And then sometimes it's just on CNS depressing medications, right? So first ruling that out. I should probably throw sleep in here, although we got it further down in the algorithm. In patients with Alzheimer's, which by far and away is the most common cause of dementia, and then the second most common being Lewy body disease, we want to be utilizing those cognitive medications. So an acetylcholinesterase inhibitor, donepezil, and the others, and then adding memantine if needed. You would skip this step if it was frontotemporal disease, right? So this is really more for Alzheimer's DLB. If you're not getting an adequate response, you don't discontinue them unless there's other side effects, obviously, which we talked about in the last talk. But we need to go further down in the algorithm. So sleep optimization is important. So we had a whole slide on that. And then starting those SSRIs, going up slowly over time. And then the antipsychotics are really for kind of further down in the list. In the emergency setting, so sometimes things happen and we just need to have different versions. Patients can't take the oral agents. So intramuscular olanzapine is what this Harvard group kind of suggested. Obviously, I put the caveat that this is really more for folks with Alzheimer's because I don't like this for Lewy body patients, right? Certainly never give them Haldol. But in some cases, we might even need benzodiazepines, right? It's really kind of trying to calm the patient down so they're not at risk of injuring themselves or others while we work on what's the underlying infection or other thing that's triggering this major change in symptoms. And then the urgent one being down here. This prazosin is interesting. I've used it a few times for more of nightmare PTSD related, and it works pretty well. But it might be a reasonable one to have in our algorithm as well. So in summary, we want to search for and eliminate triggers of worsening, right? So we talked about those. We want to involve the caregivers, right? Especially their kind of experience, but we also want to inform them of what are some of those things we can be doing non-pharmacologically. We want to optimize our medications for cognition and then try to utilize those non-pharmacologic therapies. But we do want to use the medicines when they're needed, and we do need to start low and go slow, but you need to actually go up, right? So like can't start at the lowest dose and say, well, that didn't work, we're going to stop it. We do need to go up in some cases. So really the opposite on a lot of these, but I will go ahead and pause there. I saw a few things in the chat.